to compare it to the other side. So I start with kind of motion, motor, nerve function, and then I'll move into more specific tests. So we'll just kind of do the whole deal. So I tell them to, you know, here, bring your elbows up as high as you can. You're looking to see, is their extension symmetric? Scapholinates will have a hard time doing that, or it'll be painful. And then bring your wrist into flexion, so touch the back of your hands together. And you ask them, does any of this hurt? And then rotation. So here, you got to make sure that they hold their elbows at their sides, because they'll cheat with their shoulder if they can't pronate and supinate. So you lock their elbows at the side and say palm up, palm down. TSCCs, these will sometimes hurt. And then, you know, basic motor exam. And then make a fist and then straighten it out. We'll just kind of broadly assess your finger motion. So a broad nerve test will be to spread your fingers out wide, hold them out there as strong as you can. That's your ulnar nerve. Thumbs up. That's your radial nerve, or PIN. And then thumb across towards your pinky, hold it there strong. That's your median. So you kind of broadly tested all of the nerves. Sensation, you know, do you feel me touching you here and here? Does it feel the same? This is median, this is ulnar. On the back of the hand, do you feel me touching you here and here? This is radial, this is ulnar. So you know, that's kind of just a basic exam. Now, as far as looking at the tendons, and I didn't really talk much about tendons, although you guys will definitely see tendon injuries, mallet fingers, jersey fingers, and things like that. When we're talking about flexor tendon injuries, just, you know, these all need surgery pretty much. But in order to assess the flexor tendons, there's, remember, 2 to each finger. So one, you know, to get to FDS, or superficialis, I hold all of the other fingers and then bend that one down. And you see he only bends at his PIP, because that's the FDS. Now, to assess FDP, you stabilize, bend it down, and that assesses the ability to flex the distal portion of the joint. That's looking for jersey fingers. Jersey fingers will usually be the ring finger, and basically you ask them to bend that down and they won't be able to do that. On the extensor side, if you hold your finger all the way straight, I usually kind of have them resist extension at the PIP and then resist extension at the DIP. So, you know, this will be your mallet finger. These will be the droopy ones where they can't, you know, you can passively bring them up, but they'll just continue to droop down because their terminal extensor tendon will be torn off. Boutonnieres, traumatic boutonnieres, these are sometimes tricky because they'll look just like a regular finger sprain, but they'll be fairly point tender right where the central slip attaches. And what I'll do is I'll have them flex it down, now try to bring it up into extension. And, you know, they'll be strong. I mean, you're strong, but like someone with a traumatic boutonniere will have weakness there or pain. And then, you know, when you're looking at an injury, the thing with the hand that's sort of nice is that all of the structures are really pretty close to, you know, the skin. So you can actually palpate. If you can be very specific and you know, broadly speaking, your anatomy, you can be very specific. Now, when kids are acutely injured and the wrist is a total mitten, I mean, it's very hard. Everything hurts. Everything's tender. So a lot of times I'll kind of reevaluate those a little, you know, a couple days later as the dust kind of settles, so you can be a little bit more specific. But, you know, when you're looking at, say, like the PIP joint, you can touch them, you know, press on either side. You're pressing right on the collateral ligaments. You know, you can do a stability test, hold the finger all the way in extension, pull to one side and the other. You're a little looser on this one side than the other, you know, and you'll get a little sense one's going to be potentially more painful. That indicates collateral ligament on that side. And then touch on the top and bottom. Bottom will have soreness because of volar plate. That's where the volar plate is. But everything is pretty close. You know, if they're tender right in the middle, right over the bone, well, that's concerning that maybe there is a fracture there. You know, I mean, joint tenderness can be either. That's what's tricky. But and then as we move back, you know, you also will get some ligament injuries around the MCP. I showed you the slides on the dislocations, but sprains are pretty common of the MCP as well. And to assess stability there, you bring the MCP into full flexion, because that's where the ligaments are tight. And then you push to one side and then the other. Up here, see how loose it is? Bring them down here. That's where it's tighter. So if you're going to assess for ligaments at the MCP, finger needs to be down, okay? Similarly, on the thumb, when you want to, you know, test for ulnar collateral ligament or radial collateral ligament, you don't want to necessarily do it with the thumb in full extension. They're not tight there. You bring it just into a little bit of flexion, pull this side, you feel that nice strong endpoint where you might have a little bit of motion, but it'll stop you pretty quick. Same thing with radial. And then when it comes to the wrist, you know, again, point tenderness, where do they specifically hurt? And I always ask them, okay, and if you're trying to narrow it down, I say, number 1 or number 2, press, you know, scapholunate or scaphoid, or is over on the, you know, is it the radius or the scaphoid? You know, have them compare. Sometimes they can't, oh, that hurt, oh, that hurts. Okay, well, how about which one's worse? So scapholunate, they'll be tender usually right in the middle of the joint. The kind of wrist sprain, the tear of the extrinsic ligaments that are like the strap across the back of the wrist, they'll be tender a little bit more over here to the side. LT injuries, you can do what's called the shuck test. I didn't talk about it too much, but you basically put your finger on the pisiform and the triquetrum and you try to slide it relative to the lunate, and sometimes that'll be painful or you'll feel a click. Scaphoids, tender in the snuff box, and then I also like to check resisted pronation, because again, sometimes they'll be tender everywhere. So hold your hand down, don't let me twist it. That stresses your FCR tendon. The FCR tendon runs right next to the scaphoid. So this is another way that I'll assess for scaphoid healing. So I'm watching a scaphoid on the x-ray for 3 to 4 months, because that's how long it takes for those stupid things to heal. And every exam, you know, a lot of times they'll lose their tenderness over the snuff box, but they'll be painful with resisted pronation. So that's another kind of healing indicator that I use. And then scapholunate ligaments, so put your elbow on the table. So here, and I put my thumb on the distal pole of the scaphoid, and I'll put pressure there and just relax. And you get a little bit of motion, kind of dorsal to volar, and that's normal. What you do is you kind of bring it over into ulnar deviation, push up, and then bring it over into radial deviation. You should feel that scaphoid pole with the linkage being intact. You should feel it kind of push into your hand. If you're allowed to kind of, it'll have a little bit of play. You have a little bit of play, but I still feel, as I bring it over here, I feel the scaphoid distal pole coming into my thumb. And that's just, and I find this test hard. I always compare it to the other side, because I find a lot of them to be sort of just habitually loose, especially in girls. But you just compare it to the other side. And sometimes it'll be painful on not the other. For TFCC, again, foveal tenderness, you find the end of the ulna. Is this the one you want me to look at? Okay. Find the end of the ulna, and you go right kind of in that soft spot in here. I try not to use my nail, which is a little long right now. And, you know, is it tender when I push in here? Yeah, so they'll be tender right over their fovea. The other thing is you kind of bring the wrist into extension, ulnar deviation, kind of roll it around. Is that particularly painful? Sometimes I find like that one's not always as helpful, but sometimes it will be painful. The other thing that can, in looking at TFCC, the thing that will kind of get, I find myself narrowing it down to between TFCC or ECU tendinitis. Like if they're getting like a tendinitis on the ulnar side of the wrist, that can also cause pain in this general area. Remember, ECU is actually part of the TFCC, so it becomes very kind of confusing. A lot of that is the story. Like, did you have a trauma, or is this kind of like, has this crept up on you? Crept up. So if it's crept up, sometimes tendinitis can be more of the issue. So I'll palpate along ECU. Is it tender here? Yeah. A little bit. Okay. Hold your wrist up and out. So right now this is kind of stressing ECU. Hold it there. Is that painful? Yes. Okay. And then the other test for ECU. So now twist your hand towards me. Painful?
Yeah, a little, not bad.
So the story probably suggests a little bit more ECU for you, and that would do well with potentially an injection or some, you know, potentially therapy, or depending on where you are in it. But ECU very rarely, sometimes it'll be unstable, where it'll roll around over here, which if you kind of rotate the wrist, you can sometimes feel it roll around. I don't feel that, but sometimes that's subtle. So I would probably just say do an injection if it's been going on for a long time and it's annoying, because most people don't need surgery for that type of tendinitis. An injection usually fixes it. But so when you're looking, so those are the kind of tests looking at the TFCC. But story is also important. Now, you can get a degenerative tear in the TFCC, just like you can get a degenerative meniscus tear by something as stupid as stepping off weird off of a curb. You can get that in the TFCC also. But if it kind of just creeps up, a lot of times it's more of a tendon problem. But when you're looking at the TFCC, the other thing is your D or your J. And you will have a little bit of play. I mean, I can kind of feel like I sort of can push it a little bit. Yeah. Oh, why don't we just go to questions? Because I'm rambling because I was examining your hand. I mean, that's kind of the main way that I assess it. And a lot of it will just be dependent on obviously what the injury is as far as what we're looking for. And if you guys want me to show you if there's any specific injury you guys want me to talk about, I'm happy to, or any specific exam questions or what's that? De Quervain. So that'll be radial sided wrist pain, creeps up on people, although sometimes it'll happen with a blow. I've seen it like somebody got their wrist hit and then it caused de Quervains to sort of flare up, and that's a tendonitis of your thumb. You can kind of see my thumb tendon here and your wrist. So we classically see it in new parents, grandparents lifting babies, but it can happen in a lot of different ways. But it'll cause sort of broad pain over here without necessarily a major trauma. Obviously, pain on the radial wrist, if there's a setting of trauma, you gotta just be worried about scaphoid fractures, right? Because that's the other thing that's nearby. But the test for de Quervains that I do, pull your thumb up, hold it up there strong. That'll hurt sometimes because it's EPB, or extensor pollicis brevis is one of the tendons. Tuck your thumb in like this. And then sometimes just doing that will hurt, but then you can bring it into a little bit of ulnar deviation, and that puts all this on stretch. And then the other thing, as far as, again, being specific about where you palpate, tender over the first dorsal compartment, it's right there in the radial styloid. So I'll say they'll usually be tender there, but I'll look, okay, are they tender over the snuff box or thumb CMC? Those would be the three areas where I'll push, and I'll say, okay, is it number 1, number 2, or number 3? And tell them which one it hurts, which one hurts the worst. So number 1 would be radial styloid. That would be first dorsal compartment or de Quervains. 2, snuff box, that's scaphoid. And then 3, thumb CMC. You know, that's for thumb CMC arthritis, which is fairly common, but you guys won't see it in there. But any other questions? Yes. Yes. Yeah.
Or when you feel that you want to put you in a traditional cast.
It's a good question.
Versus something or actually OT.
Yeah. So that's a really good question. So the Exos is nice because it's removable and things like that, but then it's removable. So, you know, I mean, it depends on the reliability of the kid. It depends on the fracture. If I'm trying to hold a reduction, or if there's an inherently unstable fracture, or the kid's going to be doing like football where there's major impacts. I've seen the Exos break playing football. I don't think they're as solid. So. Yeah. Well, and the receiver is tough because depending on the Exos, you know, I mean, they make the Exos kind of ulnar gutter, but it's hard for a receiver to really even play with any of that, you know. So, yeah, I mean, a lineman for sure needs to probably be in a cast, I think, in general. But again, it really depends on the injury. The Exos are nice, but they're not custom. I mean, they're custom to a certain extent, but they're not as molded to you as a cast. So I probably am a little bit more of a traditionalist in that I will lean much more toward casting than I will to the Exos. I don't tend to use as many Exos. Sometimes after surgery, or if it's really a fracture that you know, I'm not really that worried about, then potentially I'll do an Exos. Depends on. Yeah. The insurance bills the same usually for Exos. Exos gets billed like a cast. Yeah. Yeah. It again it comes back to whether or not I'm really trying to hold a fracture in place, as far as whether or not I'm going to cast them or I'm going to put them in an Exos. So.
So I have a question, and that is, we get kids that come in, fall down, etc., and we're suspecting a scaphoid fracture.
Mm-hmm.
What we tell the kids is that, yes, this is what we suspect. They go to the doctor, they come back, they say, of course, it's negative.
Mm-hmm.
Is there some directions that we need to give these parents, kids?
It's a really good question.
X-ray techs?
Yeah.
on how to find this and not waiting 10 days, 14 days for healing.
Okay, so if you're concerned about a scaphoid fracture, the x-ray techs have got to do a scaphoid view. So 3 views of the wrist, the normal kind of PA, oblique, and a lateral, will miss some scaphoids. You take an x-ray with the hand, wrist, and ulnar deviation, it brings the scaphoid into better view, much easier to see a scaphoid fracture if it's there. So I'll see people that will have gotten initial wrist films that were negative, but you do a scaphoid view because they're tender there, and then you can see it. So that's one thing, is that they need to get a scaphoid view. And that happens in ERs, and that happens all the time. About 10 to 15% of scaphoid fractures will be missed on initial films. So let's say I have a patient that, Mike's concerned, a scaphoid fracture, can you just get him into x-ray? We're not going to send him to an urgent care, we're just going to send him to your office. Fine. I see him, I do the scaphoid series, and I don't see a fracture. I tell him you have 2 options. You can come back for a re-exam and a re-x-ray in 2 weeks, and we're going to treat you with a splint or a cast like it's a scaphoid, depending on what's going on with the kid as far as sports is concerned. Or we get an MRI right now and know one way or another. I mean, that's really the option. You can, and some patients are like, I just want to know, so then I know that I can go ahead and play without worrying about it. And if the MRI is normal, done. And some people are like, I don't want to pay for an MRI right now, then you're stuck in a splint or a cast for 2 weeks. But what you could potentially tell the parent, is if you see the kid and he's like, oh, he's tender over his snuff box, you put him in a brace, they probably need some sort of imaging, but I don't know that you necessarily need to rush to do that right away, but you have to protect them in the meantime. So you could either splint them and say, let me see you back next week. If they're still tender a week in, I think it needs imaging. If x-rays are still negative, but they're still tender at 2 weeks, I'm going to push for an MRI. Does that make sense? But I think your options acutely of really knowing if the x-rays are negative, it's either MRI or cast and repeat films in 2 weeks. So.
If it's incorrect, send them and they're not going to
Yeah.
Yeah, but I'm just saying, say, down to
yeah.
the time that night.
Sure.
Say, hey, don't it's a 40 fracture.
Mm-hmm.
Not say, get this, and come back and say that.
Yeah, I think, suspect a scaphoid fracture, and they should do that. And I give talks also to the urgent cares, because a lot of times we'll just say wrist pain, wrist x-rays, and they don't necessarily know that there is a scaphoid view. That should be sort of knowledge, but it's not universally, And so I think the safety net on that is, let's say you go to the urgent care, they just get wrist x-rays, they're normal. Well, if they're real tender there, you're going to probably protect them anyway just because they hurt, right? So protect them for a week, reevaluate them. They're still tender, then they probably need a referral to some sort of orthopedist for a repeat view. A lot of those things, depending, in the middle of the night, I just wait until the next morning and just get them into the office. But I don't know that an urgent care is going to do necessarily anything. If it's not easy, our office should be, and many should be able to work them in within a day or 2, which is probably fine for, a wrist injury that's not like crooked. If something's crooked, that needs to go, if it's not, waiting for the next day for an office visit's probably fine, or send them to the urgent care, say I'm concerned for a scaphoid fracture, and they should know. Oh, sorry. I have cards if anybody wants one, or you can take a picture of it, or